Mhm. Wait, did you mean the laptop that I was given or just like my own personal laptop?
Your work laptop. Did you bring it?
Oh, no, I brought my personal laptop. I thought that was
The work laptop is for you to use it at work.
okay. I'm sorry. I brought my personal laptop, not the other one.
Hey guys, good morning.
Good morning, Priya. Hi from Weiler. So today me, Andy, and May, we are kind of in the same
Okay,
proximity.
that's why it looks different, your office. All right, so we'll give folks a few minutes and then we'll get started.
Sounds good. Hi, Kelsey.
Morning.
I saw Rachel. Hi.
Hi.
How was everyone's long weekend? Anything
Was
fun?
good. Fireworks.
Yeah.
Non-stop. And I try to put baby to sleep. I have blasting the AC on, like a white noise, so he doesn't hear the boom.
I know. I heard a lot of fireworks. Didn't actually see any.
Oh, it's
In
fun.
bed.
There's a lot like the people buy their own fireworks around my neighborhood. I thought it's
Oh,
nice
yeah.
to go. So like I guess the cops came like around after 9:30 because fireworks start like 9 to 9:30. And then they just keep booming, right? Boom, boom, boom everywhere. And then I hear the sirens drove by and then quiet. Nothing.
Yeah. We went to Randall's Island too during the day and
Oh.
biked all the way around.
Oh, nice.
Wow,
Nice.
that's nice. That was a good viewing spot, actually, Randall's Island, I think.
Yeah.
Yeah, I know.
We caught some from our roof and then they
Nice.
started to get sleepy. So we only stayed up there for like 10 minutes.
That's nice.
Yeah.
And it's hot, so it's cool to like go outside a little. Like at
Mhm.
nighttime, there's breeze, right? During the daytime, it was really hot.
So we'll give them a few more minutes.
Wait.
Okay, that must be the Weiler workroom, right? The WEPHR 49.
Andy,
That's
when you
the-
log in, did you log in your name? Is it the W something? Is you?
No, I'm at the Hutch. I'm me. I'm on my laptop. So
Oh, okay.
I'm just wondering if that is the fellows room. Just trying to assess how many of our fellows are on.
I think that's Andy, our PGY2 ID resident.
Uh,
That's the name on his laptop, I believe.
He's changing the name to Andy, so you'll see his name.
okay, Rachel, should I text him? Let's see.
Yeah, I can text them too.
Yeah, the WEP is Andy.
Yeah.
Okay. All right, Amy's on as a alias. Okay. Moses, we're gonna try to figure out how to get this ones to appear as themselves. Okay, maybe they're on.
That's okay, as long as you guys are on,
Yeah,
it doesn't have to be your name. but
yeah,
just-
that's right. As long as you guys are on, that's fine. We can get started. No worries. Okay.
And Moses are on.
All right, perfect. Okay, so everyone can see my screen, I'm assuming, right? All right.
Yes.
So today, your very first lecture, whether you're a brand new ID fellow or a ID pharmacy resident, is how to actually do the job of being an antibiotic steward. Before we even talk about that, we should talk about what is an antibiotic steward and then introduce the team here who will share with you what it is that they do and what it is to be an antibiotic steward. So, okay, I'll start. I am Priya Nori, and so in this capacity, I'm the medical director of the stewardship program, and officially we cover Moses, Weiler, and Wakefield, and the ambulatory network surrounding those hospitals, but we are starting to grow into a health system program in which all the like 11 or 12 health system sites are going to be totally synced in terms of the drugs, the formulary, the policies, the best practices, all of the above. So I'm going to kick it to Yi Guo to introduce herself, and then each member of our stewardship team, if you could just say a few words about yourself, and then we'll get right into it.
Good morning, everyone. My name is E. I'm the co-director of antimicrobial stewardship from the pharmacy end. So Priya and I are partner in crimes. We work together very closely along with our stewardship pharmacist, and also Rachel Bartash, Dr. Rachel Bartash, immunocompromised stewardship attending. So we're very excited to welcome you again here today. And you will meet me at Moses, so that's where I stationed at. I will be rounding with you on daily basis, if as long as the schedule allow me to, and also we'll talk to you about in the next few weeks, we have antibiotic lectures in the morning. We call that antibiotic boot camps. So very quickly, you'll be very comfortable using antibiotic because you're the one, the gatekeeper, approving and recommending these antibiotics. So I'm looking forward to work with you guys.
So E, do you want to kick it to another member of our team?
Sure. I'm at Weiler, so Dr. Chen.
Hey guys, I hope you can see. Good morning. Hello again. So I'm one of the other ID pharmacists and I'm stationed at Weiler, and I will be part of the team that will be helping you guys as you go through with your stewardship activities and learning initiatives. Welcome.
Great.
And I'm going to kick it to Kelsey.
Kelsey, you're mute.
Thank you. I'm Kelsey Kelman, and I am a data analyst. And so I work with some other places in the hospital, but with antimicrobial stewardship, I work very, very closely with a lot of the antibiotic use data and tracking things like antibiotic resistant organisms, the antibiograms, and a lot of the research initiatives that we do within the stewardship team.
Yep. I saw Jack just logged in. Jack, we are introducing ourselves to the ID fellows and the ID resident.
Hey guys, I'm Jack. I'm like I said before at the meeting, I'm one of the ID pharmacists at Wakefield. I primarily work with all the ID pharmacists, Kelsey and Priya. So nice to meet you guys.
And I see we have Rachel on. Rachel, you want to introduce yourself with this hat?
Sure. So you guys all know me, but I do stewardship for our immunocompromised patients. So I write a lot of the protocols, deal with bringing a lot of new agents onto formulary, particularly in the antiviral, antifungal sphere, and work closely with our transplant teams to try to limit their inappropriate use of antibiotics.
And then we have another member of our team who's Terrence. I don't see him on actually, unless he's also under an alias, but you guys will be rounding with him as well at the Moses campus. All right, so let's jump right into it. So we always like to start off with kind of like this assessment of where things stand and the lay of the land in terms of your understanding of certain core ID and stewardship concepts. So which of the following is true about patients with beta-lactam allergies, at least those that report them? A, 1 in 10 patients report penicillin allergies. B, skin testing shows that most have IgE-mediated allergies. C, IgE titers remain stable over time. D, most fail challenges with beta-lactam antibiotics. And then finally, E, patients have similar rates of MRSA and C. diff as those without reported allergies. So other than us calling on you and singling you out, take a minute to put your answer in the chat if you have one, and then we'll go through a little bit more about what the answer is and why the others are actually the opposite. Okay, good. All right, so we're seeing a couple people respond A, which is definitely the correct answer. The others, we will go through these, but you'll see that these are actually the opposite. So the only true one is that 1 in 10 patients, you will actually see in EPIC a penicillin allergy of some sort documented. So that's a lot of patients that you might take care of in a given day. And our job is to kind of debunk that, both for the patient and for the provider team. All right, so now we're going to kind of play a little game here. Let's match the suboptimal prescribing practice to the stewardship target. And this will give you some language and some tools to actually talk about what it is that you guys will be doing as antibiotic stewards when you're on call on weekends and at nights. You're actually putting each one of these different challenges into a category that then helps us to deal with these things. So when an intern or ED attending, you name it, wants to give an antibiotic for some kind of non-bacterial condition, such as COVID-19, and we saw a lot of this. Thankfully, it's better, but we still see some. What is it that they're not getting right in that scenario? Anyone want to either put in the chat or shout out after unmuting themselves? So this is an example of what do you think? Indication, that's right. So they're not getting right the indication. So they're picking a non-bacterial condition, and therefore our counseling or our recommendation to them is this is not a condition in which an antibiotic is going to help because it's a viral infection. So next, what happens when people are giving or requesting IV vancomycin for urinary tract infection? What is not exactly right there? Yeah, bug drug match. Excellent. Okay, so the thing about urinary tract infections that a lot of people don't realize, especially until they've done, I guess, medicine residency or IT fellowship, is that Vanco does not, well, putting it another way, MRSA doesn't really cause urinary tract infections except in really rare cases when the patient is also bacteremic or whatever. But for the most part, these things are caused by Enterobacterales, maybe Pseudomonas or something in a catheterized patient. And so therefore IV Vanco has no role. So when the ER is calling you about a septic patient at night, and they say, we want to give vancomycin on a patient from a nursing home who's septic, we think the urine is the source. Well, you can give them the broad spectrum gram-negative agent, but at least you can negotiate with them that please don't give vanc. The combination will lead to nephrotoxicity, and it has absolutely no role. Okay, so next, same dose of Piptazo administered to a 95-year-old female weighing 45 kgs as a 45-year-old male weighing 95 kgs. So what do we call that in the language of ID and stewardship? What do you think of the remaining choices? Yeah, so more or less, this is dose optimization. I see you guys writing some version of that in the chat. And so this is a concept that not all hosts and drugs are created equal. So if you give the same dose to those two people, you're either going to grossly underdose the young dude weighing 95 kgs, or you're going to grossly overdose the older lady and potentially give her renal toxicity. So on the two ends of the spectrum, you'll overdose the little old lady, and then the young guy, you may not actually effectively treat his infection. And if he's septic from like a diabetic foot or something, that could be a big deal. So next, we see a lot of this where teams want to give IV azithro or fluoroquinolones or linezolid or Bactrim or any of these drugs where their bioequivalency is just as good, IV or PO. Well, I kind of gave it away, but that's this concept of bioavailability. And so taking advantage of that fact is really helpful for the hospital, because you convert people from intravenous to oral much faster. You can potentially shave off days of therapy and days in the hospital, early discharge, and prevent things like CLABSI or line infections or lots of complications that can come with IV. And think about it when in these patients that need long-term antibiotics, if you send them out with an oral regimen, then they don't need a PIC, they don't need all that intensive monitoring that goes along with that. And so you're totally kind of changing the game for them in terms of their risk stratification. And then finally, when somebody would like to give 10 days or insist on giving 10 days of therapy for a routine community-acquired pneumonia instead of the routine 5 days, well, they're way overdoing the duration, okay? So we've seen all these things in practice, but now you guys have kind of like a rubric for categorizing these different types of antibiotic errors, as we call them. So stewardship is put into place. It's a law, it's a mandate by CMS and the Joint Commission, the WHO, CDC, you name it. Every single organization kind of has our back on this. And this is because most of antibiotic consumption in human beings, and probably 2/3 in agriculture, is inappropriate. And the consequences of that are very, very real. So ultimately, more people would have succumbed to antibiotic resistant infections by like 2050 than actually COVID or any of these other pandemics. The cost to the US healthcare system alone is on the order of billions of dollars. And therefore, as infectious diseases, stewardship is like tied up in that. Whether you do HIV, transplant, stewardship, infection prevention, emerging infections, there's a fundamental element of stewardship within all of that. So that's a core competency of your training. So there's multiple places in which people might be well-intended. They feel like they know what they're treating and they know what they want to give, but yet, as we saw, there's multiple ways to kind of miss the mark with antibiotic prescribing. So whether that's, too much, too hefty a dose or too little of a dose, too long, giving 2 drugs when you can give 1 drug, giving the non-preferred first-line therapy, which may be more toxic, and so many other things. So that's where your training comes into place to really tighten everybody up that you deal with and help them get on the same page and prescribe like ID, basically. So what we do works. And that's why it's hard to get rid of us and hard to justify a hospital where a stewardship program doesn't exist. Although people may sometimes associate it with this unpleasantry of being the antibiotic cops or taking away your antibiotics. No, actually, most of the time we are approving them. We are giving them what they want. We're just tweaking the dose, or we're saying, hey, did you think about this instead? Sometimes it may even be an escalation. And at the end of the day, without a doubt, the teams are always in a better place than when they went into that interaction requesting a certain thing for what they thought the patient had, because what they're getting is essentially a 5-minute ID consult to get them started on the right path. Okay. And so when it comes to these specific bacteria and fungi, a non-trained clinician, doesn't matter how experienced, doesn't really have the tools to deal with these things. And so when we're talking about crab or carbapenem resistant Acinetobacter, Candida auris, CRE, the things that we all as a group deal with on a regular basis, this is one of the things that justifies the ongoing presence and need for investment in infectious diseases, clinicians and pharmacists, because who the heck else knows how to deal with these things, right? And these are very real and they're mounting all over the world. Okay, so our team is largely behind the scenes. You guys are the front line. You're seeing the patients, you're consulting every single day. And so what we do is we kind of intervene at different spots when you guys are not yet involved, or perhaps when you're already involved and you need some customization. And we basically help at the onset get the patient started on the right set of things, and then we make certain tweaks along the way. So here's an example, a very typical patient in any of our EDs. 69-year-old male, chronic Foley, dysuria, severe sepsis. Those alarms all trigger, everything fires an epic. And so rather than having for each of those patients, somebody having to page ID or page one of you guys on call, we have built in the set of antibiotics specific to each syndrome for routine cases and for sepsis. And so they shouldn't even have to call you. And frequently they don't, except for continuing those antibiotics. So we built that in so that they can put in as little, there's little margin for error, and so that they don't have to put too much thought into it. Then later on, when there's some information back, they might call us again and be like, I need to continue giving X. And then at that point, we might see, oh, you know what? This is actually an ESBL producer, or this is this patient is on another drug that might severely interact with the thing that you want to give. So we may make some tweaks at that point. And then again, ongoing computerized decision support, where we can really do this in a very fancy way. We also work with the micro lab on antibiograms. So recently, Rachel and another one of your attendings, you're going to meet Peggy, and Kelsey and some other groups, people here, published on unit-specific antibiograms on the HEMONC floors. So the thing about those types of floors is that the same drugs that cut it on every other med-surg unit don't necessarily cut it there, because the patients are specialized. They've seen a ton of antibiotics over the course of their onc history. And so sometimes you need to do special things, or you need some special stuff. And then finally, as some of you may have seen on the Sanford Guide or on the internet, we also help people determine how long. So we help them de-escalate things, and we help them determine, okay, this patient has meningitis, how long do I treat that? So we try to give a very comprehensive rubric for providers, even without having to call ID, and how exactly to manage all these things. Okay. And again, I mentioned this is all mandatory. So that's kind of neat, because we have the backing of essentially the federal government, right? To say that people like us are needed. People with our training, infectious disease training, are here to stay, and they need to be compensated as such. We went through a lot of this already, but there's so many ways, unfortunately, you could screw up the care, the infectious disease care of the patient. Wrong indication, wrong bug-drug mismatch, wrong dose, route, duration. But when we interact with someone on the phone, let's say an intern or something, we never want to be like, you're wrong. That's the wrong drug for the wrong. We say, how about this instead? Have you considered this approach instead? And so we do want to provide kind of a good salesmanship and customer service. Why does this happen? Why do they always seem to want the thing that we don't want to give? So there's a lot of kind of psychological drivers of antibiotic prescribing. And this is an extremely fascinating topic that is very, very strong in both pediatric and adult medicine, in every setting: urgent care, ER, dentistry, on the floors, in the ICU. It's all about expectations, okay? The patients and the parents in pediatrics, the providers are expecting something to turn around right away. They want to give something that's going to turn this patient's life around, make them not septic anymore, and they want that now. And so there's a set of expectations that we don't really talk about. And sometimes us as ID, we're kind of at odds with the teams requesting those antibiotics. Patients and the consulting physicians, they desire clear explanations for why or why not we are recommending something or giving a certain antibiotic. There's a lot of concern about missing the diagnosis and the adverse consequences that are tied into that. And because the stakes are very high, we're dealing with human lives. And so that adds pressure to the situation. Still, among providers and patients alike, there's still misconceptions about what conditions antibiotics work for, and when they're actually going to get them to the goal. So for instance, if somebody has a big fat aortic valve vegetation that's continuously showering staphylococci into the bloodstream, it doesn't matter if we give oxacillin plus ertapenem or dapto plus ceftaroline. We could give nuclear weapons and that thing is not going to sterilize, because there's a big fat nidus there that has to be dealt with. And then finally, things like time. We all know about the time crunch and the desire to just give what you want to give and move on. And then finally, this vicious cycle where a patient or a prescriber says, oh, well, I gave Zosyn in that condition and that worked, I think. So I want to give it again now. And this whole vicious cycle about when things work and when they don't. And so it's up to us to kind of deconstruct these and really help people to get things right. And so there's all these core elements of stewardship. There's about 7 or 8 of them. We won't go through each specific one, but we do a lot behind the scenes. But what you guys are going to be doing mostly on the front end, on the front line, is providing a lot of education, okay? And doing this, what we call front end pre-authorization, where because of the sheer size of Montefiore, we have to set some things in place up front so that people know that here's what you can give on your own, and here's what you need an expert to help you dose and help you tweak, because it's a little bit more toxic or it is intended for extremely drug resistant conditions. Okay, so education goes so far, and trust me, they're so happy for the help for each and every one of those interactions. So an example of pre-authorization is these upfront restrictions of things like the quinolones and meropenem IV. And this is only during the day, okay? None of this stuff happens at night. Essentially, the first doses of all of these things are quote unquote free overnight. And this is intended to make it easier for them, make it easier for you guys, and let you sleep, okay? Another thing we do, which is more behind the scenes, is this action called formulary restriction, where big health system like us, hundreds of thousands of patients, hospitals spanning like 50 to 100 miles, we say, all right, if we negotiate the cost of one specific drug that we select, weighing all the best evidence so that each individual hospital is not paying for it, the retail value themselves will get a good rate from, like, let's say Merck or whatever drug company, to negotiate the cost of this drug for our patients and for the entire system. So there's a lot of stuff like that that we do behind the scenes. And then finally, another major leg of stewardship is this function called audit and feedback, where we behind the scenes look at all the things happening. We have these like very fancy dashboards where we can pick up things like bug drug mismatches, or how long someone's been on something that may be excess, or lots of different things behind the scenes. Okay. All right, so we already introduced ourselves, but do want to point out we have this awesome website that's recently been revamped, and all of our guidelines have recently been updated just in time for July 1st. Okay, so hope that you have had some time to check that out. And of course, the Sanford guide, I'd like to take a second here and hope that everyone can engage, with the thumbs up or something emoji to let us know if you have downloaded the Sanford guide app so far. And if not, please put in the chat whether or not you need help, and we can help you with that. Can you even do emojis on this thing? I don't know, perhaps not. Perhaps it's not configured for that, but feel free to drop it in the chat if you need help and if you have not downloaded that. Okay, so let's go back to this example of allergies. Why are allergies so harmful? What's the big deal? If someone has a penicillin allergy and you're like, all right, fine, let's just give them Astrinum or Cipro instead, right? That seems easy enough, probably saves you some time. Well, it turns out it's not so innocuous, because studies increasingly show that while up to 10% report penicillin allergies, when you take the time to debunk these things, only 1 in 10 are truly allergic. And so what that means is they truly have an IgE-mediated penicillin allergy, that they react with something like hives, anaphylaxis, bronchospasm right away, okay? And even if they did have that back in the day, let's say as children or as young adults, 80% of patients with IgE-mediated penicillin allergies lose that after 10 years. So the average age of our patients is, let's say, 50-something, 60-something, right? And they report either, I don't remember what happened, my mother told me, or I was a kid and I had strep throat at the time. The chances that they still have those IgE circulating around that are going to react again if we give them the same drug is exceedingly small, okay? And if you consider that we have dozens of beta-lactams, but we have far fewer quinolones or monobactams or aminoglycosides or any of these other drugs, if you take that whole class out of commission, you're left with very little. And beta-lactams in study after study are the most effective antibiotics for any serious infection that ID gets consulted about, whether it's MSSA, Pseudomonas, strep, E. coli. Heck, I can't even think of an infection besides like Mycoplasma, maybe Legionnaires, where beta-lactam is not the drug of choice. Can you guys, I don't know, type it in the chat if you can. I would be very, very interested to know about that. But for the most part, beta-lactams are the way to go. Okay. And when you don't give the right drug, when you give the alternative agent because of an allergy, what is clearly established is that patients have higher rates of C. diff, MRSA, VRE, surgical site infections, increased lengths of stay, basically all the badness. Okay. Now I'm seeing some folks say, so Weiler said, when downloaded, we have to pay for it. Curium, no, that shouldn't be the case at all. Monty pays for it, for anyone from Montefiore.org. Okay. And then the folks from Weiler said, I already subscribed, but not sure if I'm able to access Monty specific. Okay, so what I suggest you guys do is work with your second year or offline, either Kelsey or one of our pharmacists at that campus can help you out, okay? Because you absolutely should not be paying for anything because, my boss is paying for it. Okay, so E or May or combo of both. Can you explain to this? Can you explain to this audience where cross-reactivity comes from, how that's determined, and why this is important?
Sure. So basically, there are similarities in terms of the structure of the beta-lactam antibiotics between the cephalosporins and the penicillin, as you can see from this picture that Priya have on the slide. And the key is the side chain, the amine group. So when the amine group, the side chain are the same, similar, there's a possibility of cross-reactivity. But as time goes by, when we go from the first generation to the second, the third, the fourth of cephalosporins, the structures start to look a lot more different as compared to the penicillin class. So the cross-reactivity actually is very, very low. Even this slide says less than 5%, even less, like less than 3%, depends on where you read it from. So most our patient who has labeled as penicillin allergy, if they have mild reaction, as long as it's not anaphylactic reaction, most our patient tolerating cephalosporins is very well. So we hardly have to use like the Estrionan or quinolone because the patient have penicillin allergy, unless it's for severe anaphylactic reaction, then we had to use a different class. And the cross-reactivity between carbapenem is even more or less. So it's very important for us to investigate what reaction does the patient have.
Cool. Thank you, E. May, question for you. In the course of your career, for how many patients have you recommended that they go through desensitization because you are concerned about a severe allergy?
Probably 2 in the last 13, 14 years. So.
And how many patients do you think that is? 2 out of?
Oh, I've lost track.
Okay, good. So you guys see how exceedingly rare it is to require that, because I would say more than 95 or even 99% of the time, these allergies are old. The IgE don't exist. What we want to give has a different enough side chain that it's really not a concern anymore. Okay, so generally speaking, the way that we kind of go through this is if we're training the trainer, right? If we're training the folks on the floor to talk to their to talk to the patient and then come back to you with the answer to determine what to actually give, there's a series of steps. So we generally say something like, have you ever received a related drug like amoxicillin or cephalexin, let's say for a dental infection or something? How old were you at the time? Because we can take advantage of this factor of time as we discuss. What type of rash did you have? Was it like welts, hives right away, or was it a rash several days into the course? Did you require something scary like intubation or a big fat epinephrine shot into your thigh? Did you have trouble speaking? Did your tongue swell up? And if any of those things, which a patient rarely reports, then in that type of patient, an allergy consultation for either skin challenge or desensitization might be in order. But for the vast majority, you can debunk that allergy just by asking the couple basic questions. Okay, so not to beat this issue over the head, but some of this is ABIM board relevant. So I did want to go through some of these things with you. So urticaria, angioedema, anaphylaxis, anything on that spectrum. Do you guys recall which hypersensitivity reaction that is? Do you want to put in the chat? Yeah, thanks, Kiriam. It's type 1. So that's the easy one. That's the one we worry about, okay? The others are sort of more rare, difficult to pick up. So let's say hemolytic anemia, which type is that? Is that IgG or M binding to cell surface antigens? Is it T lymphocyte activation? Is it immune complex deposition? What do you think? Okay, cool. Very nice. Yeah, that's right. So this is hemolytic anemia is dependent on cell surface antibodies binding to the antigens on the surface of the RBC. So serum sickness, believe it or not, Golub and I was it last Friday? Thursday, we had a consult for a patient who was on Xolair, which is one of these new asthma biologics when somebody has really bad asthma. Then she comes in with a rash, like a fine red rash, itchy, joint aches, tachycardia, and low-grade fevers. And so they consulted us, of course, what infection does she have? But then when we looked into it, we realized probably what she has is serum sickness because of what we know about biologics. They can actually lead to immune complex deposition and then the serum sickness type thing. And of course, when somebody reports my whole body shedded off, the skin top to bottom looked like I was burned, I was in a burn unit, had a severe reaction to an antibiotic, that's a consult allergy type of situation because we want to probably avoid that antibiotic or whatever that was altogether, probably for the rest of that person's life. Okay, so now we're going to play another little game, which is called How Long? Okay. So we talked about kind of the general lay of the land. We talked a lot about allergies. We talked about dose optimization. Another way that we see frequently that people kind of overshoot the mark when it comes to antibiotics, and you're going to see a lot of this as well, is that they have the right indication. They pick the right drug. They even do great with the dosing, right? But then they just order it for way, way, way too long. And so we see this frequently in like urinary tract syndromes or even bacteremia due to urinary tract syndromes. So how long would you treat a 40-year-old female presenting to her primary care doctor's office with dysuria and frequency without fevers? So we'll start with the low-hanging fruit. How long would you treat, let's say, basic cystitis? Yeah, 3 to 5. Perfect. Okay, so even our pediatrician knew that 3 to 5 days for a 40-year-old lady. What if it's an ESBL E. coli and she needs meropenem because there's no other choices? Does that change the calculus of how long? No, right, exactly. So the bug doesn't matter. It's the syndrome. And so regardless of it's a extensively drug resistant thing or a very routine thing, it's cystitis. And so you treat for the 3 to 5. Perfect. Okay. So this is now more likely the type of consult you're going to get. 75-year-old male with an enlarged prostate, chronic indwelling catheter, dysuria, and fever. And he's in the ER and he's being admitted. So how long would we treat a guy like this? So if the last lady was 3 to 5. Good. So probably a median of like about 7 days. Okay. At the 7-day mark, he's probably good. Beyond treating beyond that for an extra 3 more days, plus minus benefit. So if he's already good at the 7-day mark, consider yourself good to go. Of course, there's other things here that without remedying these modifiable risk factors, this is going to keep happening again and again. So then large prostate, of course, is going to continue to cause problems, as is the indwelling urinary catheter, etc. So part of our recommendation for a patient like this is that, are you on medications to shrink your prostate? Are you getting your catheter changed at some frequency? Are you following up with urology? Do you need something to, acidify the urine and prevent bacterial overgrowth? Okay, now this lady, 29-year-old pregnant female with essentially pyelonephritis, and her blood culture is also positive for E. coli. How long would we treat her? What do we think?
Dr.
Okay,
Nori,
so
don't we
this-
have to treat, don't we have to wait for test of cure in a pregnant patient?
So not necessarily. So in pregnant ladies, you do treat the condition of asymptomatic bacteriuria. So only pregnant ladies and people undergoing invasive urological procedures. But in this situation, tests of cure of the urine is not necessarily required, because you're going to kill, basically it's not difficult to kill the bacteria coming from a urinary source, because the levels of drug that we achieve in those spaces is very high. Nor is it really necessary to do a blood test of cure. It has become our clinical practice to make sure the bacteremia clears, and then saying, okay, we recommend X number of days for a urinary source, or, X number of days from the clearance of the blood culture. But that's one of these dogmas that's being challenged more and more. Okay. In a pregnant female, of course, you probably want to take it a little bit slower, make sure that she's on the road to recovery. But generally speaking, all these tests of cure are not absolutely necessary. Guys, do you have anything to add to that? Anyone want to chime in? May sees, so our Weiler campus is where you're going to see these obstetric patients. And so May is our obstetrics expert. May, do you, sorry to put you on the spot, do you have anything to add in terms of how you would manage this type of patient?
Yeah, nothing really more to add. You're absolutely correct. We generally treat for the duration of the illness. And then in some cases, if there are patients, someone that's, let's say, multiple stones or other risk factors where we are concerned about an unremovable nidus of infection, you may then repeat a urine culture just to make sure that they're not still colonized. And then maybe prophylax them until the pregnancy.
Okay, so that's a good little nugget right there. So without, if they have a nidus, then that changes the calculus somewhat. Thank you, May. Okay, and then finally, our personal favorite, because this is one of those sign on and off consults. 80-year-old female from a nursing home with a fall, positive UA, positive culture, no fevers, no dysuria. She was recently started on a muscle relaxant. How long would you treat someone like that? Even if, okay, let's say the urine culture shows an extensively drug-resistant Klebsiella, how long would you treat? Good. All right, very good. 0, absolutely. We're in consensus about that. So regardless of how scary the situation looks, this is what we call asymptomatic bacteriuria, and a ton of elderly female, elderly males as well, especially those from nursing homes, have this condition. 25 to 50% of the elderly women, 15 to 40% of elderly men. So the bottom line is, even if the urine is cloudy or smelly, which by the way, neither are signs of UTI. Okay, on their own, those are not, those do not count. Even if they have pyuria, even if they're growing very scary bacteria in their urine, elderly patients presenting with a fall and or confusion or whatever, in absence of urinary symptoms, don't even test for UTI, forget treating. Okay, leave that alone because it's only going to lead to excess antibiotic use. So another major resource for you guys this year. Have you heard of Brad Spellberg? If you have not, well, today is the day, okay? Dr. Brad Spellberg is the Chief Medical Officer of the LA County Health, like city hospital system. He's an infectious diseases physician, and he's importantly an antibiotic steward. Like that's one of his fundamental roles. He's extremely well known in ID and IDSA, and he started this whole movement that's absolutely taken off, which is shorter is better. So what he did is like he looked at all the available data on how to treat these very common conditions that we deal with all the time. And he looked at studies to show the traditional longer duration, and then he looked at how many studies and the quality of those studies to see which of those challenged that very long duration and what was the outcome. So you can see that in all of these conditions, the shorter duration, so let's say for CAP 3 to 5 versus traditionally, before you guys were born, 5 to 14 days was the equal result in trials, okay? And each year, this list gets added to because more and more conditions, except for a few things like multi-drug resistant TB or prosthetic joint infection in which the device was not all the way removed, there's more conditions for which shorter is equivalent or better than longer. Okay, so definitely check this out. This guy is so funny. He posts a lot of really good stuff on social media. So finally, in the time that we have left, a couple minutes, we're going to kind of go through just some day-to-day stuff, okay? And then we're going to kind of role play and practice how to be a steward. So what is your role in all this? Our stewardship program is essentially 24/7, but that is inclusive of you guys. So our team handles the daytime. So we sign in at 8 a.m., okay? And we go until 5 p.m. when we cover the pager. And then you guys sign in at 5 p.m. and you're technically logged in all night. But remember that 10 p.m. onward, except for like anti-malarials and things, which they should call you, and you should call your attending, everything is essentially free. Anything that they've ever heard of is for free. They've not really heard about things like cefiderocol or, aridavancin and like things like that. So therefore, any of the meropenums, the Zosins, the whatever, those things are free. And so know that regardless of whether we are the ones logged into the pager, if it's a weekend, if it's a holiday, if it's whatever, we are always here to help you figure out how to treat a patient. What is the dose? Do we have this drug? What do we need to do special that's for this patient? Our ID pharmacists are amazingly available. I'm also available, but trust me, I'm not, besides like, what do I do about this monoclonal antibody patient? I'm not going to be nearly as much help to you as these guys. So remember that even when things get taxing and when it's the middle of the night and you're put in an extremely stressful situation, all you have to do is practice breathing. All you have to do is remember that they're not asking you to fix the patient and make them wake up from sepsis and walk out of the hospital. They just want to know what to do right now. And if you don't have an answer to that, it's perfectly okay to say, I don't know that right now, but here's what I'm going to do. Give me 5 minutes. I'm going to track down my attending or an attending. We're going to talk about it. We're going to work this out together. Okay. All right. So I think by now our second years taught you where to go to actually log on to the different individual pagers. If you have questions about that, please pop it in the chat. And right, so here are the numbers that will be etched in your memory from now until forever, the rest of your career. Moses Pharmacy, Weiler Pharmacy, Wakefield. And if you get one of these rogue pages or consults or something about a COVID patient that needs monoclonal antibody or needs something, okay, just kick it to us, covidasp@montefiore.org. We try not to get you guys too involved in any of the COVID related patients or their therapeutics. Unless you're interested in that, we're happy to have you. Okay, so here are the things you need to obtain from the requester when they're calling for approval, okay? You want to understand, well, first of all, you need the patient basics, the demographics, the MR number, date of birth, at the very least, so you can look them up in Epic. But it's good to understand, well, what does that person think they're treating? What do they want these antibiotics for? So you can get started and to kind of be on the same page as them. The creatinine clearance is super important because that helps us dose everything in a very nuanced way. If they're on CVVH, that is also very important because we want to be sure not to underdose those people who tend to have more serious infections. If a patient has an allergy, put the ball in their court. Teach them how to obtain the history in the way that we just went through, okay? Now, how long do we approve these antibiotics? Well, if you're really unsure, something like 24 or 48 hours is great because then inevitably it'll come to our, it'll come under our radar of the daytime stewardship team, okay? If this is a continuation situation, like the patient was in the ICU for 7 days, now they're on the floor, they're being transferred, we want to continue this thing. Wait a sec, 7 days covers almost every situation, minus osteo or Staph aureus bacteremia or something like that. Are you sure that 7 days is not enough? So all they need is a little hand holding sometimes, and you can just be like, you know what? This is a good time to stop since they're in an observed setting and you can catch anything that may happen if they decompensate. And so you as the expert can give them the little nudge to feel comfortable and actually just stop. A couple tricks I want to mention at this juncture. 2 smart phrases, .crcl. I live by that thing. That gives you the most up-to-date creatinine clearance. That's always more accurate than the one you'll see in the BMP section of Epic, which uses a different calculator. So this is what we use, .crcl. I even put it in the notes so that I know exactly what doses to give the patient. And then, was it Jack? Jack, did you make .zosyn? But one of you guys made .zosyn, and it's like, it's amazing.
Yeah,
So
.zosyn dose.
Yeah. So what that does, that Zosyn pulls up this table of dosing for different thresholds of creatinine clearance, and it's so dope. And we'll keep those coming. You have suggestions for others you'd like to see. We're happy to create those and then disseminate them to ID. Okay, so at this juncture, you guys are still kind of calling the pharmacy with these approvals. But sometime like maybe toward the end of the summer, when you guys get a lot more comfortable with this, we will switch on the electronic access where you just punch in those approvals, just like your second years in us, okay? And we'll remove that step of having to additionally call pharmacy. So when you call pharmacy, usually goes something like this. Hi, this is Priya Nori. I'm calling from ID. Can you take down an approval for me? And here's the name, here's the MR number, or the date of birth, or the location. They basically need 2 different identifiers, okay? And then you give them the dose, the drug, and how long. And if it's a patient we are not following, let's say you're just called like in the morning or overnight or whatever, 3 days, okay? 3 days gives enough time to sort everything out. If it is one of your patients and you know what they have, you know what you want to do, feel free to approve it for, a solid week or something, just so it doesn't fall off. You guys are all extremely sweet, extremely nice people. Remember just to be patient. Essentially all of healthcare is short-staffed right now, and that includes pharmacy and all these other people who help with the process. And so, just give it a couple minutes. If it's taken a long time, just text one of us will throw the approval in for you electronically, but soon enough, you'll have that access. Remember that when you're signing out on Fridays, give a comfortable duration of approval for stuff so that it's not falling off over the weekend, or you're not inundated with stuff on Monday when you come back, especially a long weekend like what we just had. For ED patients, so the EDs do need approval for piperacillin tazobactam, and this is very deliberate. We've debated this hotly for years and years, and they unfortunately just cannot be trusted with this drug. They get it for free. They get the first dose for free when there's a sepsis activation. But beyond that, they grossly overdo it. I mean, like, damn, like giving it to every asymptomatic bacteria, giving it to every COVID, like they just, because they're time pressures, we understand, but we built in this check and balance so that they kind of are more mindful about it. Okay, so when should you actually give broad spectrum antibiotics? When should you have a low threshold? Okay, I would say in sepsis, in a truly septic patient, you're not clear of the source, patients coming from a nursing home, patients recently hospitalized, really don't know what's going on, or the color is just not backing down and it's not really worth your time and energy. Give a dose, give even 24 hours of something. Call one of us, call your attending for backup. If you feel like this is kind of something you can't work out on your own, absolutely go down that route. But bottom line is, like, don't lose yourself over this. Don't lose your energy. Just kind of roll with it, because you'll be much better off on the back end. Know that we are tracking all this stuff, okay? So you don't have to worry that, like, oh no, I am totally tipping the balance by approving a couple of doses of Zosyn. Our team, Stewardship, we are tasked with tracking all this stuff on a monthly basis. And so this is where Kelsey comes in. She helps us track a lot of this important stuff. And so you guys are dealing with one patient at a time, but we're dealing with one service at a time, or one entire group of providers. So we have your back, okay? We're in the background and we have your back, so you don't have to worry about it. I mentioned this at orientation, but we're gonna set you all up with the stewardship curriculum, which has this awesome new bugs and drugs primer. You're going to do this during your micro blocks. Okay. So we'll look at when those are, and then we'll set you up with access. And then finally, our website, definitely bookmark that. And then just some last minute pearls about the pager. So there's going to be times when you're rounding, when it's the weekend, when your pager is blowing up, but don't worry about it. Just take one at a time. Okay. There's nothing you can do. You're just one human. You can only take one page at a time, and time only goes in one direction. Before you know it, your call will be over. Don't let a difficult interaction ruin your day or your night. When in doubt, you can ask for an ID consult. You can approve that dose of whatever, but you can ask for an ID consult. One of the attendings will see it in the morning. Well, our team is here to back you up 24/7. Always okay to give one dose while you're waiting for stuff to happen. And then, just be cool. These people might become your closest friends down the line. You never know. And that has happened to me. I can name multiple examples. Okay, so I don't even know if we have time for this. I think we're reaching the hour. So we'll skip this part, but we'll email you all these slides. Okay, we'll email you the PDF of these. And essentially, that's it. Let's take a look to see if there's any last minute questions. Okay. So what is the consensus on the atypical cap duration? So for the most part, atypical cap, we have urinary markers for Legionnaire's. So because most Legionnaire's disease, except in maybe very compromised host, is Pneumophila type 1, that will get picked up on your urinary antigen. And if that's negative, definitely stop. Actually, we send a lot more urinary Legionella antigens than there are actual cases. In the summertime, it's very real. Legionnaire's outbreaks happen in New York City virtually every summer. But if it's the middle of winter, I don't even know why we give azithromycin. So other smart phrases, .crcl, .mrsa nair, .venco. So we have a ton of these. So feel free to use all of the above, okay? So you have another lecture, so I'm gonna, our team is gonna bounce, but feel free to contact us anytime with questions. We wish you all the best of luck, and we are all here. We have your back, okay? It's gonna be great. It's gonna be fine. You can do this. Okay. We'll see you guys later, okay? Thank you.
Okay.
Bye.
I